Hello, so let's continue with our series on the wrist and hand. Yeah, generally just the wrist and the hand. So we were to discuss the applied anatomy. Okay, so remember that the carpal tunnel forms the anterior relation of the wrist. So you're allowed to discuss carpal tunnel syndrome at this juncture. So remember, the carpal tunnel is formed by bones forming the floor and the flexor retinaculum forming the roof, and it contains 9 tendons, 4 from flexor digitorum superficialis, another 4 from flexor digitorum profundus, and a tendon of flexor pollicis longus. And of note is that the median nerve is within the carpal tunnel. So those are the contents of the carpal tunnel. Ulnar vessels and radial vessels are not within the carpal tunnel. So when you have compression of the median nerve within the carpal tunnel, that's what you call carpal tunnel syndrome. And it's usually seen in some diabetics or repetitive use of the hand, like in typists, associated with rheumatoid arthritis or in pregnancy. Those are the conditions you can find carpal tunnel syndrome. And the median nerve is usually compressed. And remember, before the median nerve enters the carpal tunnel, it gives a branch, sensory branch, towards the thinner part, or rather, yes, the lateral aspect of the hand. So that branch, sensory branch, is given before it passes through the tarsal tunnel. So the sensory branch is not compressed in the tarsal tunnel. However, what are the symptoms of this carpal tunnel syndrome? Because the median nerve is compressed, the innervation of thinner muscles is going to be compromised. So you have weak thinner muscles or muscles of the thinner eminence with associated atrophy of the thinner eminence. So the muscles of the thinner eminence. And then you can have the pins and needles sensation. And then usually they get the pain, and the pain is relieved by the shaking of the hand. So you can get muscle wasting at the thinner area, or paralysis or weakness of the thinner muscles generally. Then we have discussed scaffold fractures. We said they commonly occur at the waist, where the blood vessels are, and it's the narrowest portion, so it's prone to fracture. And pattern of blood supply is usually blood is supplied from the distal part of the scaphoid before the proximal. So when you have a fracture and you rupture the vessels at the waist, blood can get to the distal portion but may not get to the proximal portion. So the proximal part of the scaphoid undergoes a vascular necrosis. So these scaphoid fractures, patients present with pain and tenderness around the anatomical snuff box. So those are the common applied anatomy. Of course, you can get dislocation of the lunate or necrosis of the lunate. So those are like examples of other applied anatomy cases. You can also have fracture of the distal radius that's around the wrist joint. So they present with fork appearance of the hand, like due to the distal fracture of the radius. Okay, it's called coreless fracture actually. So then we discuss first carpal metacarpal joint. It's a synovial type of joint of the sellar variety. What are the articulating surfaces? The base of the first metacarpal and the trapezium. Then we have factors that increase the mobility of this first carpal metacarpal joint. Number 1, the extensive articular surface, okay, as well as the shape of the articular surfaces. So those increase the mobility. Then the capsule of this joint is very lax, and the ligaments are oblique. Okay, so these increase the mobility of the first carpal metacarpal joint. Which ligaments are found at this joint? We have the lateral ligament on the lateral surface of trapezium to radial side of the metacarpal base, and then you also have the palmar and dorsal ligaments, and these are palmar on the palmar and dorsal surfaces of the trapezium to the ulnar side of the metacarpal base. So the palmar ligament is on the palmar surface of trapezium and inserts onto the ulnar side of metacarpal base, while the dorsal ligament is on the dorsal surface of trapezium and also inserts onto the ulnar side of the metacarpal base. So what are the relations of the first carpal metacarpal joint? On the palmar surface, you have the thinner muscles. On the dorsal surface, you have the long and short extensors. Medially, you have the dorsal interosseous and the tendon of flexor pollicis longus. while on its lateral aspect, you have tendons that are going to the thumb, like abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis. Those are found lateral to the first carpal metacarpal joint. So what are the movements that occur at this joint? It allows all movements in all direction, which is circumduction. So you have flexion by flexor pollicis brevis, some element of flexion by opponens brevis and flexor pollicis longus. Extension is by abductor pollicis longus, extensor pollicis brevis, and extensor pollicis longus. Then abduction is by APL and abductor pollicis brevis. Adductor pollicis causes adduction, while opposition is by opponens pollicis. So these are the muscles that cause movement at first carpal metacarpal joint. Again, obeying the Hilton's law, this joint is innervated by radial nerve, median nerve, and ulnar nerve. But because remember, the muscles of the extensor compartment cause movement at this joint, so radial nerve. The thinner muscles such as opponens, median nerve, and then some element of ulnar nerve because of adductor pollicis that has dual innervation. What's the blood supply to the first carpal metacarpal joint? Mainly the radial artery. So basically that's it about the series on the hand and the wrist. Remember, you can have spread of infection from the hand to from the different compartments of the hand, but mainly from the central compartment to the flexor compartment through the carpal tunnel. So you can spread infection towards that direction. Thank you. Other hand applied anatomy of the hand that you need to remember, like deep contracture when you have fibrosis of the palmar aponeurosis. Then in cases of we have trigger finger, you have mallet finger, you have claw hand, like in ulnar nerve injury or Klumpke's palsy. That's claw hand. Then there's wrist drop in radial palsy or Saturday night palsy, or fracture at the midshaft humerus. Okay, so it will give you wrist drop because you can no longer extend the wrist. Then which other conditions of the hand? We have hand of benediction, which can be caused by either median or ulnar nerve. So you need to go to the internet and look at the images of these conditions so that you're able to remember how they appear. But material on this we have already shared on the Telegram group, the images of all these malformations. So you can just go and check on the media files